Okay, so we'll start the post-lunch session. So I thought someone was ringing the bell, but when I went out, no one was there. So it's just a ghost in the machine. Okay, yeah, so we're back. I'm very excited to introduce our next speaker, Arjun Manrai, who is an assistant professor in the Department of Biomedical Informatics at Harvard Medical School, where he leads a research lab that works on applying machine learning and statistical modeling to improve medical decision-making. And he's also the co-host of a podcast, right, that focuses on the role of AI in medical diagnosis, clinical use of genomic data, and reproducibility and safety challenges for medical AI. So all topics we're very excited to hear about. So yeah, please take it away, Raj. Thank you.
All right. All right, great to be here. Thank you to the organizers for inviting me, and it's been a really good meeting already, and hopefully this will continue the morning topics pretty well. So just as an overview of today, I'm going to give you a very quick sort of lab and research overview for my group. And then I'm going to try to make the argument that there's a lot that we can learn about evaluating AI, which is our big focus, and I think the focus of a lot of folks in the room, from studying things that we would not consider AI, very familiar, simple statistical equations that are used ubiquitously in clinical medicine. Then I'm going to tell you about my favorite case conference series. These are the New England Journal of Medicine Clinical Pathological Conferences. The case reports have been published since the 1920s until today. And then I'll introduce you to a system that we built in my lab, and of course this is a talk about AI, so I'll show you that system solving one of these cases, and then use that to frame, I think, the current progress and the sort of future directions for us going forward. So as was mentioned, I have a lab at Harvard Medical School. We're in the Department of Biomedical Informatics. We work on these sort of two broad areas that seem quite different from one another at the surface, but we end up using very similar tools, asking very similar questions in these two respective areas. And so we spend a lot of time thinking about traditional clinical equations, like some of the ones that have been mentioned earlier today during the morning. So the EGFR for estimating kidney function based on serum creatinine, ASCVD risk scores, for example, who's likely to have a MI or a stroke, PFTs, pulmonary function testing measures to assess how well your lungs are doing, and so on. And in those traditional clinical equations, I'll show you an example of some of those projects, but these are equations that are used ubiquitously in clinical practice, not sort of a theoretical 5 or 10 years away. They're being used at every hospital around here at very, very large scale. And then the other big area for my lab is on AI in medicine, developing systems, evaluating systems for general diagnostic reasoning, management reasoning, and so on. Big focus for us also increasingly is on how humans and machines collaborate together in medical diagnosis and in management reasoning. And we like producing PDFs and papers, but our real goal is to have clinical impact. So we're very, very clinically focused as a group. We work with a lot of doctors, a lot of the clinical societies, and try to move work over from the sort of theory, hey Ziad, and into practice. All right, so what could we learn about AI from a very familiar clinical equation, something that none of us would consider AI? And so if you consider this question, who's at risk of an MI, a heart attack, or a stroke? If you're a physician, there's a good chance that you've come across or that you regularly use something called the pooled cohort equations. There's a 2013 incarnation of it. And just a few years ago, there's a pretty big announcement because a group that was affiliated with the American Heart Association updated these equations to the new PREVENT equations. Now, they did a few things. They removed race as a predictor. They added kidney function as a new predictor. And then most importantly, I think those got a lot of the sort of, the attention, and they're important, but most importantly, they recalibrated those equations with contemporary data. So they updated those equations to predict who's at risk of an MI or stroke with new data. And the question that we asked in my lab is, we're observing this, seeing this happen. We're not affiliated with that group. But what we want to know is, okay, it's one thing to sort of recalibrate, maybe improve prediction or improve calibration with contemporary data. But what might change clinically after we recalibrate those equations and we're using the modern incarnation? And so what we found is we used nationally representative gold standard data from the National Health and Nutrition Examination Survey. And this was not very surprising to the cardiologists that we spoke with, but I think maybe the scale of it or the estimate of it was quite surprising. We found that this seemingly good thing, which is recalibrating these equations with contemporary data, would reduce eligibility or create newly ineligible 14 million Americans or greater than 14 million Americans for statins. So, very widely used, very important drugs for preventing MIs and strokes. Now, student James Diao, a superstar in the lab, has been working for many years on these types of questions. He's led a series of investigations in our lab around understanding the impact of race adjustment or removal of race adjustment from commonly used clinical equations. So if you look at EGFR, there's an adjustment factor that was historically used, about 1.2 and a little bit lower in some of the other equations, that was used to change the estimate of EGFR or an estimate of an individual's kidney function based on their same serum creatinine. And there too, we did the same type of analysis where we found after hospitals started removing race directly from the equation, it might surprise you, the way they were originally removing race was to directly delete the coefficient and give that, use that equation for everyone. We found there too significant expected impact on Black patients from CKD diagnosis, so diagnosis of kidney disease, to who's eligible to donate a kidney, to drug dosing and contraindications, and so on as a function of how those equations were being changed. So it seems like a minor thing, just delete that coefficient, but at population scale, nationally, these are major changes. Similar story if you look at, okay, how do I get rid of the emojis? It's trying to make me score what the significance is of this. Okay, so similar story if you look at pulmonary function testing. And so we published a paper in the New England Journal of Medicine where we looked at the implications of race adjustment or removal of race adjustment from those equations. And there, it's not just clinical changes. I think for EGFR, it's also not just clinical changes. There are occupational, financial decisions that are attached to how these equations are operationalized. So the argument that I tried to make a year ago or so in this piece is that there's a lot that we can learn about evaluation of AI models that are sometimes harder to decipher, inscrutable, black box-ish, right? From looking at the questions that we ask, elucidate values, and understand our traditional simple clinical equations. Things like those equations that I just talked about, EGFR, ASCVD, pulmonary function testing measures, equations and biomarkers, ways of analyzing them that none of us would consider AI models. If we look at the training data and the model development, the questions that we ask, how representative are those data, right? Similar questions that other folks have asked all morning. If we look at how those models are developed, what variables are we using as predictors explicitly or implicitly, and what are we actually trying to predict, right? It's often sort of like, covered up or something, but what we're actually trying to predict and whether that's a good prediction target for clinical practice is often, not the subject of much scrutiny. What is our target variable? So if we look at those traditional equations, those are the questions that we ask in both training data and model development. And if we're thinking about AI models, those are very similar questions that are helpful to understand how AI models are used and what questions we can ask to elucidate what values and what behavior will emerge out of use of those AI models. Which corpora are used to train large language models or computer vision models like the ones that Marzia was talking about a few hours ago? How are we defining our outcome in the AI model, right? Are we discretizing a continuous variable like diabetic retinopathy into more than mild diabetic retinopathy or not? And what changes are introduced in behavior of those models by that choice of that target variable? If we look at large language models, how are we fine-tuning those models, right? Which humans are we selecting to create examples that are helpful for the models to be used in supervised fine-tuning or reinforcement learning from human feedback? All of these things profoundly shape the behavior of both those simple clinical equations and those new AI models. And then what I really want to focus on is model use. So this doesn't get, I think, as much attention, especially in sort of more machine learning focused settings, long after the model is created, right? The training data have been selected, the model's been trained, we've decided how we're specifying the model form, we fit the model. I think those areas, the first two areas there, they occupy a lot of attention, a lot of time, but long after those weights are fit and the model is set, how the model is actually used can profoundly shape its behavior and the impact on different populations, right? So if you look at the traditional clinical equation setting, we're going to debate endlessly about what the right cutoff point is for prostate-specific antigen, for example, right? Because we're balancing the risks of false positives and false negatives on either side, and there's competing ways to estimate those and to understand the utilities that are attached to individuals for different types of errors. Now, if you look at AI models, after the large language model is trained, right, after your vision language model is trained, how it's steered can profoundly shape its behavior. Give it a different role. Tell it it's an insurance company. Tell it's a doctor. Tell it it is a doctor, to act as a doctor. Tell it to act as a patient. And you will get very, very different behavior, either explicitly or implicitly, with that same model. Switching gears a little bit, I think this was mentioned. In addition to doing research, I am very actively involved in a journal, NEJMAI, which is a very clinically focused AI journal from the publishers of the New England Journal of Medicine. And then I host a podcast with my good friend, Andy Beam, called AI Grand Rounds. We've had Ziad on there, a few other folks in the room. And oh, good. I even put it here too. So perfectly to embarrass him in a couple sessions you'll hear from him. So I reflect a lot on why I get to work on these very clinical problems. And I go back to this training program that I went through as a PhD student. It's called the HST program. It's between Harvard Medical School and MIT. And it's like the most clinically immersive PhD program that you can imagine. So you take, as a PhD student like me, I'm not an MD, you take pathology, genetics, cardiovascular, pathophysiology, renal, resp, anatomy, and then most importantly, you spend 2 summers in the clinic wearing short white coats. They sort of think of you as a poorly functioning medical student, but you round with the teams, you present histories and physicals, you really understand the uncertainty in medicine, what doctors have to go through, and I think you become like a little bit less annoying when you're speaking with physicians, and you really understand them a little bit better, and so I think it's really helped us form a lot of very close clinical collaborations. I'm going to switch gears a little bit and tell you about one of my favorite things to do in this program. And so I learned about these case records in Massachusetts General Hospital as a sort of iconic or classic case series that are used to teach expert diagnostic management reasoning to medical students and then all through the rest of physicians' careers. And so there's a lot of these case series. This is one of the most well-known ones. This is, I think, maybe the first case in that case series back in 1923. They were started by this physician, Dr. Richard Cabot, back in the 1920s, and I'll show you what they look like. I'm not going to read all of this, but they start with this sort of dense mass of text, right? That's called the presentation of case. It explains kind of what's going on. So we learn this is a 49-year-old man in this case with hypoglycemia. He's admitted to the hospital because of the hypoglycemia. He was well until 3 hours before admission. Then he had altered mental status at work. His colleagues noticed, his cell phone starts to ring. He allows it to keep ringing. Eventually, his colleagues find him on the floor of a conference room, and he's obtunded. He's making non-purposeful movements. They call emergency medical services. They take a finger stick glucose. It's low. It's 39 milligrams per deciliter. They give him intravenous dextrose, and then he's brought to the emergency department, and so on. And so always starts with kind of a presentation, what's going on, what brings the patient to the hospital. Then it goes through his social history, occupational history, relevant past medical history, and labs, and so on. And then this is my favorite part of the case. You learn what an expert who's not typically someone not involved in the management of this patient, how they're thinking about this case. And so they bring in this expert, Dr. Amy Bauman, who's much more eloquently and articulately than me. She summarizes, this is a 49-year-old man who presents with recurrent symptomatic hypoglycemia. He has weight gain recently. He was eating 5 meals a day, intermittent morning dizziness that resolved with food. His medical history includes Bell's palsy and hypoglycemia that hadn't been evaluated previously. Social history was notable for his job as a nurse in a medical facility and his family history of diabetes, and initial labs reveal a normal A1C and a low blood glucose. Then we have a little historical interlude on Dr. Alan Whipple, Whipple's triad in the 1930s. And then finally, Dr. Bauman concludes constructing a differential diagnosis to determine the cause of hypoglycemia. There are 3 broad categories to consider: systemic illness, ingestion of drugs or toxins, and endogenous insulin production. And I'm not going to go through this, but she systematically goes through each of those different categories: systemic illness, ingestion of drugs or toxins, endogenous insulin production. This is what expert diagnostic reasoning looks like, where they're explaining how those different etiologies, different conditions match up or don't match up against the patient's presentation. They're citing the literature where relevant, and then she's identifying a most likely diagnosis and the sort of robust differential diagnosis. So the patient's age, presentation, clinical history, and duration of symptoms are most consistent with a diagnosis of insulinoma. This is a tumor of the pancreas, and to establish this diagnosis, I would initiate a supervised fast to monitor for symptomatic hypoglycemia. In addition, I would measure serum levels of glucose, insulin, C-peptide, proinsulin, and beta-hydroxybutyrate. So we have her most likely diagnosis, a tumor of the pancreas, and then we have also the next steps, which is what tests should be ordered to confirm that diagnosis. I love these cases because they have the sort of expert reasoning that you can read on, but then they have what actually happened to the patient. This is a case that's already happened. We learn what the care team thought, and it turns out they also suspected insulinoma. They performed that same test that she recommended. Again, she's independent of the case. They performed that supervised fasting test, and lo and behold, it was consistent with an insulinoma. We then learned that this led to an abdominal CT scan. If you really squint from the back, you can see those two little arrows that are pointing to a mass on the pancreas. Then that led to endoscopic studies to localize, to size the mass on the pancreas, and then this led to resection. They removed the tumor, and then they looked at it under a microscope, and we have a full pathological discussion there. And we learn that Dr. Bauman was indeed correct. This is a well-differentiated insulinoma. So she was correct without any of that additional information, of course. We learned from the care team and from that final pathological diagnosis. But not only that, we have the follow-up. We learned that the patient, after the tumor was removed, is doing well. They have lifestyle changes for the treatment of prediabetes, annual A1C checks, and we get a follow-up on how they're doing 9 months later. And this is what expert reasoning looks like. It turns out that these cases, these very same cases, have been used to study AI systems for many, many decades. If you go back to 1959, classic paper in the history of sort of medical AI by Ledley and Lusted, Reasoning Foundations of Medical Diagnosis. I took the excerpt there. They also brought in these same cases. They imagined them as sort of an aspirational gold standard for achieving medical reasoning or expert medical reasoning with computer systems. Fast forward to the 80s. If you look at internist rule-based systems, which were in vogue then, solving lots of interesting problems, albeit typically a little bit narrower. This system, which was one of the best known, maybe the best known of the time, published in the main New England Journal of Medicine, used these very same cases to evaluate how good their system was, and they compared it to clinicians and to the discussants themselves in the cases. And then there's a paper published in JAMA by my close colleagues, and Adam Rodman and Zahir Kanji and Byron Crow, and they looked at GPT-4, which is now an ancient model, right, by today's standards. I think this was published in 2023, actually, and not 2024, and they looked at the summer it was published in the summer of 2023, shortly after GPT-4 came out, and a 5 there is based on 2 physicians blindly reviewing the quality of the final diagnosis from GPT-4 against what the final diagnosis was in the actual case. This shocked folks. These are hard cases. They're hard, they span all of medicine. They didn't do anything fancy or special with the model. They just looked at the final diagnosis, and they found that in the majority of time, even back with GPT-4, the models were solving, at least in a final diagnosis sense, these cases. But what we focused on and what we've gotten very interested in is trying to dig into this a little bit more. The final diagnosis is only really part of the story. Many clinical reasoning skills are what you saw when I was presenting Dr. Bauman's analysis of the case. They're lost if we only look at the final accuracy of the case. How well does the model reason over images? How well does it integrate labs and images together? How accurately or how exhaustively does it take into everything that we're seeing in the presentation of case into account when it's providing its differential diagnosis? What citations is it providing? Is it grounded in current literature to actually come to that final diagnosis? So many of the actual clinical reasoning skills that we would want of an expert AI system are really not tested very well or tested at all in only looking at the final diagnostic accuracy. So if you think about, and this is a theme in our lab, how are we actually evaluating the humans, right? We have that human expert discussant. This is Ether Dome at Massachusetts General Hospital. The cases used to happen in there, so it's a little bit more, I think, a little bit more of a sort of, proper, like it looks like a medical room where people are there to sort of scrutinize a case presentation. There's like an Egyptian mummy on the side there, very Boston, right? And you are there on the hot seat, right? You're in the podium. You're at the podium. If you're the expert discussant, you're only reacting to that presentation of case. And your colleagues, you see them all there. They all have printouts of that presentation of case, and they're all there to see, how you're reasoning, to see if you get it right. And only after you present that presentation, your differential diagnosis, do we learn what actually happened in the case. So you're up in the hot seat there. This is one of the discussants from one of the recent cases presenting. And then you write up, and the New England Journal of Medicine publishes the expert discussant. And they get it wrong sometimes, right? So you're sort of sticking your neck out there. You're taking a risk. Most of the time you get it right. But you're taking a risk. Yes?
So why do people do this?
Why, as the doctors?
Yeah, why?
It is a storied and amazing thing to demonstrate your sort of diagnostic prowess and your expertise. And so it is an honor. Like one of my good friends, Adam, actually just did it last week. He described it as the honor of a lifetime to be invited to the CPCs. And so, it's like, why do you go to the dunk contest, right? It's like to show off your skills. And so NEJM will and NEJM publishes it too. And NEJM publishes your full written differential diagnosis after the case. So thinking about all the sort of, the diagnosis in here, yes?
Is there anything in particular about the types of cases that?
They span all of medicine. They span all of medicine. They do have some particular areas. They're not like a random sampling of it, but they span all areas of medicine. Okay. So we have gotten obsessed with this question, thinking about not just the final diagnostic accuracy, but all those reasoning skills that are being demonstrated by the human in this case. And the question that we've been asking in the lab for the past couple of years is, could we create an AI discussant that can do what the human expert does in these cases? And so fortunately, Dr. Richard Cabot started the series, and his name lends itself to Dr. Cabot, which is the AI expert discussant that we created to solve these cases. It starts with a presentation of case, just like what the human expert responds to. And the first thing it does is it finds similar cases. You can specify which decade, but it finds similar cases to those cases using the sort of machine representation of all cases, embeddings of all the published cases. And then in this iterative loop with OpenAI's O3 model, this has now been updated to one of the newer models, it searches the literature. So this is sort of a RAG approach where it has access to a medical search tool, a literature search tool, iteratively searches the literature and then composes a written differential diagnosis. You can also interact with this conversationally in sort of faster mode, uses a different model, doesn't need to have citations for that one, so we don't have that sort of slow lookup step. Then, if you want to create a video conference, we have the same system. Essentially, write a script. It creates a set of slides. So these are LaTeX Beamer code slides, along with a script and a narration that we feed to a text-to-speech model, stitch them together, and what you get is a video presentation, reasoned through the 5 to 10 minutes, similar to how the human expert does it, of these cases. And so I'll show you, where this is going. I'm going to show you one of those live videos. But first, I'll just show you a version of this that's maybe a little bit more humorous, because you can specify whatever decade of CPCs to anchor your expert to. You could take a case like this, a 63-year-old man who's at the hospital because of syncope. He had 13 years before admission. He had a cardiac arrest, was found to have multivessel coronary artery disease, so he underwent this CABG procedure, this heart bypass, right? Bypass procedure. At another hospital, and so on. And eventually go to sort of a prompt. If you have the sort of modern incarnation of Cabot, it would provide something that you wouldn't really raise sort of eyes at and would be kind of a normal response to what's going on in the patient and Cabot's thoughts. But if you have the 1920s version of this doctor simulating how a 1920s NEJM CPC expert discussant reacts to a case like this, it's horrified, right? What is this CABG procedure that you're subjecting this patient to? Didn't exist, right? It wasn't invented until many decades later. So much for the trustworthy clinical facts. Intermixed with them are extraordinary reports of barbarous procedures which no prudent physician could countenance. We are told that 13 years earlier, surgeons undertook to sew miscellaneous lengths of artery and vein upon the coronary vessels of the beating heart, an enterprise so ghastly that one must doubt the accuracy or sanity of the narrators, right? This is a large language model simulating a 1920s New England Journal of Medicine expert discussant reacting to a modern case. All right, same exact case.
For joining today's.
Actually, let me pause that. So same exact case that I presented earlier, Dr. Bauman. You remember the final diagnosis was an insulinoma, And the recommended test was a supervised fasting test to confirm that diagnosis.
Good morning, everyone. Thanks for joining today's
This is the
CASE
system.
conference. I'm Dr. Cabot, and we've got a really intriguing episode of recurrent hypoglycemia in a middle-aged man. So, let's dive right in and, tease apart the key clinical threads. All right, so starting with the storyline. Our 49-year-old registered nurse is sitting in a morning meeting when colleagues notice he's, just zoning out, fidgeting, not answering his phone. About an hour later, they find him on the floor, eyes open but clearly not purposeful. Emergency medical services pop a finger stick, 39 milligrams per deciliter, very real hypoglycemia. Dextrose goes in, he wakes up, classic reversal. He describes a dream-like feeling before the crash and has retrograde amnesia for most of the morning. Now, the longer history is almost more telling. For about 3 years, he's had early morning dizziness that he treats with candy or breakfast, pretty suggestive of fasting episodes. Over the past 3 months, he's actually gained a pant size, which, defensive eating often pushes people toward weight gain. 2 years ago, he had a facial droop episode. Glucose that day was 64 and was labeled Bell's palsy. No meds except vitamins, rare alcohol, and no illicit drug use. Family history of diabetes on insulin is present. But remember, he's not on any of those meds himself. Exam after dextrose is pretty bland. Afebrile, heart rate low 80s, pressure mid-hundreds over 70s, respirations 14. BMI 27, no stigmata of endocrine disease, no hyperpigmentation, no hepatosplenomegaly, neuroexam normal now that he's awake. So the body is otherwise healthy. All right, here are the admission chemistries. Most things are stone cold normal. Renal function, liver transaminases, electrolytes. 2 numbers pop out. Lipase is mildly up at 67, and of course the glucose of 36. That's the smoking gun confirming true hypoglycemia. Everything else is reassuring. No renal or hepatic impairment that could drive low sugar. The tox screen is squeaky clean. Serum ethanol 0, salicylate and acetaminophen minimal, and the urine panel is negative across the board. Hemoglobin A1C is 5.4%, which tells me his average glycemia is totally normal. So we're not missing swings into hyperglycemia here. So putting that together, we've got a previously healthy 49-year-old with documented severe fasting hypoglycemia, recurring for years, with compensatory weight gain, and no systemic illness. That's the problem I need to solve. Let's spread out the big differential. First, critical illness and organ failure. Sepsis, liver disease, bad kidneys. Second, endocrine shortages, cortisol, growth hormone, thyroid. Third, inborn metabolic errors. Fourth, the IGF-2 secreting tumors. And then we have drugs and alcohol, factitious use of insulin or sulfonylureas, and finally, endogenous hyperinsulinism, insulinoma, nisidioblastosis, or those quirky autoimmune antibody syndromes. So trimming the list, normal vitals and labs knock out critical illness. Normal sodium and blood pressure make adrenal insufficiency improbable. He's 49, too old for silent congenital metabolic diseases. No cachexia or masses, so IGF-2 tumors fade. Now, factitious hypoglycemia is tempting because he's a nurse, but, the chronicity, the weight gain, and the nocturnal symptoms aren't what we usually see with surreptitious injections. That leaves endogenous hyperinsulinism. In adults, insulinoma is, by far the commonest culprit. So my working diagnosis is an insulin-secreting pancreatic tumor, an insulinoma. The key clues are recurrent fasting neuroglycopenia, normal A1C, defensive weight gain, and absence of any exogenous agent. Next steps, we need the biochemical slam dunk, a supervised 72-hour fast with paired glucose, insulin,
Can be a little bit funny.
C-peptide, proinsulin, dihydroxybutyrate, and a sulfonylurea screen. Once that proves endogenous hyperinsulinism, we localize arterial phase CT, maybe MRI, perhaps endoscopic ultrasound, and we get the surgeons involved early because resection is curative in the vast majority. Key take-homes. Always verify Whipple's
Now it's showing
triad,
off.
separate fasting from postprandial patterns, grab that critical blood sample during the episode, and remember that defensive snacking leading to weight gain is practically the calling card of insulinoma. Early endocrine and surgical collaboration is, the fastest path to cure.
So that's pretty much spot on with what the experts said, right? The diagnosis and the next steps, and then I think the model is just showing off a little bit at the end with teaching points. So we've been trying to stick our necks out a little bit with the model and really try to get feedback from physicians about how this is doing, where it falters, where it goes right, where it goes wrong. So we organized an actual event at Harvard Medical School where we had Cabot go on one of the cases. We had the audience select a random case, and then we had one of the AnyJam editors come and present their expert differential diagnosis. If you're interested in this more, this was covered in this very nice article written by a physician. He's very thoughtful about this, Dhruv Kolar, and that was in the New Yorker a couple months ago. And then the New England Journal of Medicine just published Cabot's diagnosis, the first AI diagnosis in the CPCs. In this case, 282025. This was back in October, so about 2 months ago. There's a differential diagnosis from the human expert, who's a legendary diagnostician around here at UCSF, Dr. Gurpreet Dhaliwal. And then we introduced Dr. Cabot in case conference format. And then we have the human expert's diagnosis, we have Cabot's diagnosis. There are videos produced by the system, the video that was provided by Dr. Gurpreet Dhaliwal in solving this case. And so you can judge for yourselves, but I think it is a very different time than I imagine with the New England Journal of Medicine publishing these types of diagnoses. So this is 1 or 2 cases. You should be skeptical now. I cherry-picked this, right? Generated 1,000 of these. We did a larger comparison, 62 blinded comparisons. We had 10 physicians, 5 attendings, 5 residents from Harvard evaluate Cabot's written differential diagnosis versus the one that was actually published in the New England Journal of Medicine. We were hoping that some of the time it would not be able to be picked up. We were very shocked. 3/4 of the time, they think the AI diagnosis is the physician's diagnosis. They rated it higher in overall quality, in diagnostic justification, in citation quality, and in learner engagement than the actual published New England Journal of Medicine differential diagnosis. If you look at just final diagnosis, this has only gone up. There's an estimate from a Google paper a few years ago. These are very hard cases across all of medicine. So physicians with search, the estimate was about 40-50%. They get right. Physicians without search, 20 to 30%. They have been the estimates that they get right. And the latest models, O3, and I think it's a little bit better now with GPT-5, and with some of the other models, are upwards of the 80s and 90% or so. So this is to say, I'm just going to wrap up here. I'm going to zoom out a little bit. These types of results, right? USMLE, passing by AI models, we all take those for granted now, right? Professional competency exams, we know AI models are really good at. They're so good now, we're taking these results, which we would not have taken for granted a couple years ago, but we take them for granted so much so that now we question the value of these types of exams for humans. I think this was also a result that surprised a lot of folks. I think you could quibble about some aspects of the paper, but chatbots are able to be on. They're able to provide empathetic responses as rated by humans, and they're able to provide very helpful responses again, as assessed by humans in blinded ways. It's not just hypothetical, it's not just retrospective case series or even held out cases. AI is being used by patients at massive scale. This is one of the big cases you might have seen on the news where a boy had seen 17 doctors over 3 years, and to end her son's diagnostic odyssey, the mom put in everything she knew, and ChatGPT was able to diagnose this condition called tethered cord syndrome. She took that to a new doctor who was able to review the imaging studies and then help the boy. So this is all to say, if you were to tell me that we're now solving CPCs, AnyJam is publishing AI diagnoses, we have loved ones delivering real value, ending diagnostic odysseys for their loved ones with AI models that are routinely available, and AI is being considered empathetic, I would have said all of this is science fiction, right? This is totally unimaginable just a few years ago. It really is progress, but I think AI and our evaluations are still very limited. I didn't talk about hallucinations, confabulations. They're still an issue, still something that we're grappling with. Very little data on how humans and machines will work together. I think this is going to be, looking for a good research problem, I really recommend this for the next few years. I think we have very little data on how collaboration will look like, how we'll avoid things like alert fatigue and automation bias, and how we keep the human in the loop or on the loop, adjacent to the loop, whatever, part of the loop you want to be on. We have very little data on the clinical grade evidence of AI. This is probably going to largely come in the form of RCTs. I think we have equipoise for conducting some very interesting studies. Some are being launched now. Many more will be launched over the next few years. We really need clinical grade evidence, not just the retrospective case series that I showed, but really prospective RCTs that these things work. Very little data on how performance is changing over time. I think we mostly have one-offs, demonstrations, but we have very little data on how on the same task these models tend to change. And going back to where we started with the simple clinical equations, we have very little systematic study of what values are embedded in these models or embedded in their use. I took a off-the-shelf, O3 model, and it's a brilliant PhD student, Thomas Buckley, who did the hard work here, but we were able to turn it into an AnyJam expert discussant with some prompting, with some RAG, with some literature search, and with some machine embedding of all the AnyJam cases. But there's many, many more questions that we have left to answer about understanding how we steer these models and we change their behavior. All right, I'll stop there. Yes?
Those cases that.
Are they in the training data?
Yeah, that's my
Okay, so yes, I absolutely believe that many, or at least some to many of those cases are in the training data. One answer, we don't really know because we don't know what's in the training data for many of the leading models or most of the leading models. The only way to really test that, held out cases. And so you have to use held out cases or use cases after the pre-training cutoff for those models.
I only asked because some recent mathematical breakthroughs problems that were solved turned out to have been
Exactly.
in the training data.
No, it's a super important question. I think ultimately we need held out evaluations of it. And so we've done several of those. We've looked at after the pre-training data, or we've used cases that are coming, there's literally one of our collaborators has cases that have never been on the internet because they're one of the cleanest possible data set. They're only on physical records at the Beth Israel. And we're only going to use them once for the final eval. Yeah.
I got a question.
Yep.
Oh yeah, just a quick one. So you mentioned hallucinations at the very end. So I was curious, the video you showed us, was there any hallucinations?
No hallucinations
at all
in that one,
video?
but there have been.
We can't really judge.
Yeah. No hallucinations in that one. There have been hallucinations in other ones.
And how do you have like a method to
Yeah.
discover those hallucinations, given like how dense and sort of
To discover them or to ameliorate them?
or like how are you evaluating
Yeah.
the hallucinations in this multimodal way?
Yeah. So
Do you get like experts to read
Yeah.
everything?
Yeah.
and-
So experts read these. Experts watch those videos. And our physician colleagues are the ones who point out we find that once we just change the medium in which they engage with this, right? It's like a video case conference that they're familiar with. That it's quite entertaining to them to actually be able to watch these, understand it, and so physicians identify those errors, they point them out to us, and then there's a whole literature now on how you build guardrails around these systems. You can use other models, even the same model, but another instance of it to actually check for hallucinations. You can develop rubrics to sort of monitor for these hallucinations. So we've built guardrails on the next incarnations of it, but the system actually absolutely does hallucinate. Yeah. All right.
Sorry. There's a question.
Yeah.
Yep.
Just a teeny little question. There were times when the voiceover
Mispronounced?
wasn't using the exact words that were
Yeah.
on the screen.
Yeah.
And I'm just wondering whether or not the voiceover was independently kind of accurate, or whether you need
Yeah.
both the text and the voice to be as accurate as possible.
Yeah. So I would think of it as sort of we're trying to model this as analogously to how the humans are going to respond to it. And my guess is if you look at my voiceover over my slides too, I probably had a couple things that were a little bit off too, right? Or I wasn't exactly saying what was on the screen. I'll tell you mechanically how we generate it. So we have the written differential diagnosis. We have the sort of slides that are generated, and then we feed those to generate a script. And sometimes it goes off script a little bit compared to it. In general, it adheres pretty closely to what's on the slides. The other tell, we had to really iteratively do this with physicians. The first versions of this were awful. They were I would never play it here. It just sounds like robot that's disconnected from reality. But this was a lot of iteration with our physician colleagues. There's a prompt, you can see it's part of the system prompt. We had to engineer the uhs and the ums because us, it doesn't say and ever by default. And so we had to put the uhs and ums, which led to this amazing rabbit hole of looking at what the base rate is of uhs and ums. And there's an amazing paper in the CS literature on the rate of uhs and ums in typical human speech. And so little things like that. It also mispronounced some words, it used to say syncope as syncope, which is just it gives it away, right? It still can't pronounce its name, Cabot. It's Cabot, but it was saying Cabot, Crabot, other things, and so we just made it say Cabot, Richard Cabot. But there's little things like that too. Thanks.
Thank you so much. Thank you again.